So we are back. We are in May. We are referring to ourselves as we, third person, because that's what happens when you get to the dizzy heights that I have. So who knows, maybe one day you'll refer to yourself as we. No, I'm an I. Hi, Jackie. Dizzy heights, you and me, Jackie. It's you and me. Anyway, we don't need anyone else. That's fine. We can ask the question. Oh, and Corin, Jackie and Corin. There we go. Hey, we are here. We being me, Jackie, and Corin, not necessarily me being not doing a third party, third person referring to myself there. I got myself some questions, and I'm going to get cracking on this one because time is money, people. So I'm looking well, am I? And real plastics, look at that. Jackie, Corin, and Naveen, if it is Naveen. Right, what we got? We got, how can I avoid rippling when choosing an implant? I'm sure there was more to this question. Naveen, good to see you. How can I avoid rippling when choosing an implant? Okay, so wow. Okay, so there's different things that can cause rippling. So there's things, I guess, let's split it into things related to the implant and things related to your body. So things related to the implant means the kind of how the implant's filled, how well the implant's filled. Some implants have got more kind of gel in them, so a bit tighter, so a bit firmer, but therefore less likely to ripple, whereas some have less. We're veering more towards a kind of firmer implant these days than what we used to use, which means that they feel a little bit firmer, but they will tend to ripple less, and they will also be safer if the shell fails. So it's always a trade-off with these things. You got to think there's always going to be, how can I avoid rippling? Well, you can have a firmer implant. Well, then that's going to be a firmer implant. So there's always a trade-off with anything, because if it was like I can avoid rippling by having this kind of implant, everyone would have that kind of implant. So there's got to be reasons people don't have that kind of implant. The other thing is smooth implants tend to ripple a little bit more than the rougher implants, the more textured implants, which become a bit more integrated. Probably the least kind of cohesive fill would be a saline implant. So saline implants would ripple more. We don't tend to use saline implants in this country. As far as I'm aware, I've never really used them, and I don't really know anyone who uses them. But anyway, if indeed you did have a saline implant, then moving to a silicone and certainly a more cohesive gel implant with a rougher surface. I find that I use a lot of the polyurethane foam implants, which ripple less than, say, a smooth implant, but they have their own issues, don't get me wrong. So I don't know if some people don't use them, I know that, because of their issues, but I try and give a balanced view to patients. In terms of the patient, in terms of the patient's body, the main thing is like how much cover you've got over the implant. So if you're very slim, it's great, well done. If you're slim, well done you. But it does mean that you are more likely to get rippling. You're more likely to see the ripples of the implant. What I do in the clinic, I've got implants in here somewhere. What I do in the clinic is I kind of hold an implant up like that, and I say, look, that's what they look like. They all look rippled in the body. The question is whether you can see that rippling. And that really really depends on how much soft tissue you've got covered over your chest. As a kind of easy marker, what I normally say is that if I can see your rib cage, if I can kind of go like that, and I know I'm going to hit a rib, if I look at you and I go, boom, I'm not going to hit a rib, then I would say that I would worry that I'd be able to see your implants, basically. And so that in terms of rippling, so I would worry you get more rippling. So therefore, if you haven't got much cover over your body, then the main thing we can do is put them underneath the muscle. So that's probably really the main indication for putting the implants underneath the muscle, if you're very slim, if you can see your rib cage, then you're going to be putting those implants underneath the muscle to give them better coverage. Now, let's be clear, the muscle only covers it in the cleavage area. Muscle goes like that. It's a pec major muscle. So it only covers it in the cleavage area. So it doesn't cover it laterally. So you might still get some rippling laterally. So that is one way you can avoid rippling. I know it's not related to particularly choosing the implant, but it's a way that you can avoid rippling. The other thing you can do, as well as, or indeed instead of putting them underneath the muscle, is things like fat grafting. People are doing this now, fat grafting over the top of the implant. As I say, some people are doing this hybrid, I think they call it breast augmentation, where instead of putting it under the muscle, you would do put the implant in and then do some fat grafting over the top, which would give it an extra layer of cover over the top, and that would make it less likely to have visible rippling. It is quite an expensive procedure, fat grafting, and it is quite subtle in my hands, so it's not something that I regularly do, but it's definitely a thing that's seems to be sort of gaining popularity out there in the world, this hybrid breast augmentation by putting a bit of fat graft over the top of the implant. And certainly for an established cause of rippling, there are not many things you can do except rather unhelpfully say to people, if you put a bit of weight on, that would help, but that's not very helpful really. So the only things you can do in an established case of rippling is really putting them under the muscle if they're not already under the muscle, and putting fat graft over the top of them. But as I say, that is subtle. It can potentially damage the implant, potentially introduce infection. All sorts of things can happen in a bad way for if you are doing fat grafting. But that's probably the main way to fix a case of rippling. So yeah. Have I done that? Have I answered that very well? I don't know. Done my best. Always a balance. Rippling versus the risks of putting them under the muscle, which has its own, has its own risks. So there are benefits of putting under the muscle, but there are risks of putting under the muscle too. Happy to expand on that if required, if anyone's interested. I've got a just early on. I don't know. I'm not sure. I've been told. Looking at my questions, no, right. I've been told I've got to advertise the See and Treat clinic. So I'm going to take this opportunity to advertise the See and Treat clinic. Something we've been doing for a long time, but a bit like I'm trying to get it. I've done a brochure. I made a brochure for it over the weekend. Very proud of myself. You can see the brochure by going to bit.ly /See and Treat. Now I can write that in Facebook, can't I? I can write. Oh wait, what have I done here? Please rate this chat. What? Oh God! Press the wrong button. Okay. I thought I could write. Can I write in the chat in Facebook? I don't think I can write in the chat in Instagram. Well, I could write a comment. Maybe not. Okay. Well, if I could write a comment, that's what I'd write. bit.ly /See and Treat, all one word, SEEANDTREAT, and you can see the brochure, which I designed and made, all my own work. And again, I'll share this with you because we've not got many people here. I'll share this with you. What I'm trying to do in my own mind, this is what happens in my mind. I'm trying to think a bit like We Buy Any Car. We Buy Any Car, they say enter your reg number. Yeah, enter your reg number, 30 seconds, you get a quote. And that's quite kind of catchy, bang, done. Now, you'll see if you look at my brochure, I've actually got a 5-step guide. I'm not happy about the 5 steps. I'm like, 5 steps? We Buy Any Car don't do 5 steps. So it says like, send us your photo of your mole. This is for See and Treat, is for like moles and cysts and things we can do under local anesthetic at the clinic. So it's like, send us your photo of your mole. By WhatsApp or email, and then we'll get back to you with a quote and what can be done, and then you book your See and Treat appointment, then you have your See and Treat appointment, and then we look after you, and then like that. And that's 5 steps. I think 5 steps is wrong. We Buy Any Car's just got 1 step, isn't it? It's just send us your reg number now. Send us your reg number now, and you get a quote. Is that a song? Maybe it's not a song. No. Anyway, that's what they say, and I'm like, Send us your WhatsApp picture now. So I feel like I should just say, send us a WhatsApp picture. Not by email, not by phone. WhatsApp a picture of your mole or tattoo or cyst or lipoma or whatever. And we'll get back to you, but I don't know how to sort of... Anyway, it's work in progress. But yeah, bit.ly/see and treat. Check out the brochure. Let me know what you think. Yeah, so I've got to promote that on this, although none of the questions are relating to that. So I did say, if you want me to promote it, put questions related to it. Yeah, that's how you promote it. But anyway, that's what I'm dealing with. Okay, this question: how long after breastfeeding can I have a breast augmentation? So I say minimum 6 months after finishing breastfeeding, because your breasts will change in size and shape, and they need to sort of recover, if you like, after breastfeeding. Or when you are breastfeeding, they get bigger, they swell up with the milk, and then when you stop breastfeeding, they involute, they sort of get smaller, and they can droop, you can lose shape, you can lose volume, but it's unpredictable to what degree they're going to involute or get smaller or droop or what have you. So you kind of need to really get them maximally involuted before you would want to do breast augmentation, because if they get even smaller, you would maybe put a bigger implant in, or if they droop more, you might put a different shaped implant in. So you really need to get them to a stable position. So I would say 6 months is minimum. The other thing you've got to consider with this question is that you've got a small child at home. So it can be difficult looking after a small child if you're having breast augmentation. So I normally say, for me, I think if the child's about a year old, that's a little bit easier to manage, because they're kind of like walking, hopefully, around that sort of time. So a little bit easier to manage. So those two things may or may not fit together. Obviously, you're breastfeeding for 6 months, and then wait for 6 months, that will be a year. But I normally say a year is kind of what you're looking at. Now, I completely understand that maternity leave is a year, so a lot of people want to have it done within their maternity leave. So people want to have done surgery within that time. So it's not written in stone, you can have it done within that time. But if you ask me from a surgical point of view, I would say usually a year after birth, 6 months after breastfeeding is kind of the sort of time scale I'd be looking at. But different for everybody. You can't really generalize too much, because everyone's different, and some people's breasts might take a little bit longer to settle. And if your breast is taking a little bit longer to settle, you might want to wait a bit longer. If your breasts have settled quite nicely, you might think, actually, they've settled, they're stable, they're not going to get any smaller or any more droopy, so I'm happy to have it now. So it is a bit variable, but 6 months after breastfeeding is kind of like my ballpark. Would I need to have my gastric band deflated prior to having surgery, Fleur De Lis? So yeah, good one. This is someone who's asked the other day. What I would say to this is I've asked this patient to talk to their gastric band person, because I think I got the impression there was talk of them having it adjusted. So if you are having your gastric band adjusted, if they are trying to get it right, then you need to have this done prior to having surgery, because you do not want to have weight fluctuations after surgery. So if they are thinking of doing things to your gastric band, then I would say, yes, you need to have it deflated. You need to have it stabilized prior to having surgery. Now, if you've had the gastric band in for years and you haven't had it, changed, and they're just kind of leaving it where it is, personally, I think it's absolutely fine to leave it there. We are going to speak to the anaesthetist. The problem with the reason the question is asked, because you don't want to have a kind of a tight gastric band, which is going to increase your risk of aspiration, being sick, sort of thing, and then bringing it up into your lungs. So that is the worry about having a very tight band. But as I say, I don't routinely tell people to get it deflated prior to having surgery if they've had it in for a long time and they're stable with it. I haven't got a strong view on it. We would let the anaesthetist know to see if the anaesthetist would want that to happen. But from a surgical point of view, as long as your weight is stable, that's the main thing that I'm concerned about, is we don't want any significant weight fluctuations after surgery. And so you really need to be stable with your weight, with your band in that respect. I want a brachioplasty, but I'm wondering if it's possible to extend the brachioplasty to remove my saggy back boob area too. Yes, it is. So a brachioplasty, a normal sort of standard brachioplasty, goes from below the elbow here, and then as a kind of L shape in your armpit. But it is possible to take the side, what are you calling it? A saggy back boob area. So the side bit here. So you can extend it down onto your lateral chest wall to take that excess skin from there. I mean, it does give quite a long scar that goes from just above the elbow down onto your chest wall, but it's perfectly reasonable to do that. It is quite a big operation, as any of these sort of body contouring operations are. But yeah, that is an acceptable extension of a brachioplasty to take the lateral chest, to tighten the lateral chest wall. We're getting through these, aren't we? Right, you know what? I think I'll have a mint. Do you? There you go, mint thumb. Do you have a catheter during breast enlargement surgery? No. I don't give people a catheter for any. It was definitely no for breast enlargement surgery. Breast enlargement surgery is an hour long, so there's no need for a catheter. As a general rule, I don't like putting tubes in and things. It's an increased risk of infection and things. So try and avoid tubes and bits and bobs like that. I mean, if you are thinking, would you have a catheter? That would be more for bigger operations. Things like maybe combined procedures, tummy tucks and breast procedures. But even then, we tend not to use a catheter. What we might do for a longer operation, as I say, we wouldn't do this for a breast augmentation, but for a longer operation, like for instance, a tummy tuck and a breast procedure, like a breast augmentation or a breast reduction or something, we might do an in and out catheter at the end of the operation, simply for comfort, because we don't want you to wake up in the recovery and being bursting for the loo and you can't really move very well, you can't get up very well. So we would perhaps do an in and out at the end of the operation. So we empty your bladder, so put the catheter in, empty your bladder, and then take the catheter out. So when you kind of wake up, it's not really it's not in there, but we don't leave the catheter in. The one thing, obviously, because you've got a tube going to, it's another bit of plastic inside your body with a risk of infection and things. But the other thing is, after this sort of surgery, we kind of want you to move. We kind of want you to get up and about. So nothing too crazy, but certainly going to the loo is actually not a bad thing. So if you were kind of an extremist and you couldn't move and you were in retention and you couldn't wee, yes, you could have a catheter. But I can't. That just doesn't happen. I'll be honest. That doesn't really happen. Can't remember the last time we've done a catheter, and that's for the bigger operations I'm talking about. For breast enlargement, it would be pretty much unheard of, I would say, having a catheter, because, as I say, operation's only an hour, so you're only out of action for a couple of hours, so you don't need to go to the loo in that couple of hours. These bigger operations take 5 or 6 hours, so we're giving you fluid during the operation, so those ones are a bit more reasonable to think about catheters, because we don't want you waking up being bursting for the loo. But for a breast enlargement, that's not going to happen. So yeah, it's a definite no for breast augmentation, and it's a potential in and out for the bigger operations. And I can't think of any operations where I would leave it in dwelling. I think sometimes I seem to remember I have had patients kind of request it because they're worried about going to the loo afterwards, and certainly that's understandable. So I would say to them, you've got to keep moving, and then maybe take it out earlier the next morning after the operation, if a patient requested it, if they knew that they were potentially going to need to go to the loo a lot and they didn't want to have that if they just had a big operation. So we would sort of honor that if someone requested it, and that has happened, but it's pretty rare. As a general rule, you don't need a catheter for any of these kind of ops. How effective is lowering the pocket on a high riding implant? Well, that's like saying how effective is surgery. I mean, yeah, you hope it's effective. I mean, a high riding implant in my hands is usually for implants underneath the muscle. I normally say to people, I think this stat probably would hold true. I hope it would. Whenever you kind of make up stats in your own head, you usually find you hopelessly underestimate the true incidence. But anyway, with that in mind, I normally say about once a year I have to lower a set of implants, and they're pretty much always under the muscle. So a high riding implant is usually a problem with an implant underneath the muscle, with the muscle holding the implant high, and you need to lower it. However, I'm gonna have had cases where it hasn't been effective. So I have had cases where I've lowered it and it's still stayed high and things like that. So you know, but that's like you know, any surgery can kind of fail. But I you know, wouldn't go into surgery thinking it's going to fail. It usually works. I don't know what to say. How effective is lowering the clock? I mean, it's not a common operation, you see, so I don't really have big numbers of it, but it's usually effective. I mean, what I try and do, so you do an inferior capsulotomy, so you make an incision in the capsule from 3 o'clock to 9 o'clock to the lower half moon of the capsule to let the implant come down, and usually there's a little bit of muscle still attached in the lower pole, which is pulling the muscle up. So you'd go and release that bit of muscle as well, because as I said, it's pretty much always with the implants under the muscle. Yeah, that is what you do, and you would hope that it works, and it usually does. That's really unscientific, isn't it? I don't know if you want a number or something, but yeah. The thing is, if you've given it time to settle and it hasn't settled, what else are you going to do? You got to, and if it doesn't, then you might have to try again. And as I say, I have been in that unenviable situation where I've had to try again. I've had to do it and try again, but fortunately not commonly. I've had a breast reduction and lift. Yeah, well, breast reduction and lift. That's breast reduction is a lift. I was an H-cup, but now I wished I'd had implants to make them more fuller. Could anything be done to make them more fuller above the nipple area? Well, yeah, you could have implants. And this is the thing about breast reductions and lifts, really. You got to be kind of aware about what sort of shape can be achieved with this sort of surgery, because when you have natural breast tissue, it always settles. And I try and make it quite clear with patients what sort of shape can be achieved with a breast reduction and a lift. As I say, they're the same operation. A breast reduction and a lift. It's just a reduction makes them smaller and lifted, whereas a lift just makes them lifted and keeps them the same size. But the point is that when the tissue is pushed up high, which it is with these operations, it doesn't stay, it always settles. And so you have to kind of try and manage the expectations prior to surgery to make it clear to patients that you won't get that fullness up there. Like, at least when you can wear a bra and push it up, but you could do that even before you have surgery. But when you've done the surgery, they always settle, and the sort of look that people are perhaps thinking of when they think of having this sort of surgery is with they're in their mind they've got breast implants, the look that you get with breast implants, and you can't get that look without implants. You can't get from the nipple up, you can't get a bump. You know that bump? You get that sort of shape. Yeah, not that sort of shape. So you get a concavity, not a convexity in the upper pole with a normal natural breast with breast tissue. It always settles to a concavity in the upper pole. If you want a convexity in the upper pole, if you want a bulge in the upper pole, that has to be an implant. You can't get that with a breast lift or a breast reduction. You can get it in the first couple of months for sure, but then once the tissue's settled, in my hands, it pretty much always settles to that sort of convexity. And if you want that fullness, that has to be an implant. The problem you got in these patients, particularly the breast reduction patients, is that an implant is going to make you bigger. So my advice, and this is a personal thing, I don't know, you know, everyone's going to have their own views on this. My feeling on this is that I would not recommend having implants just to get that fullness in the upper pole. I would say, look, it's natural, it's how it looks. Kind of accept it, if you are happy with the size, and particularly if you don't want to be bigger. If you don't mind being bigger, then maybe you could consider it. But if you want to be smaller, so if you want a breast reduction, if you want smaller breasts, don't start thinking about having implants, because implants are going to make them bigger. And then you get into a situation where you have to think about having implants to get the shape in the upper pole, but then actually reducing the breast more to accommodate the volume that the implant's going to take. So you're actually taking away healthy breast tissue and replacing it with implant, which is not something that I particularly like the sound of, and I don't particularly recommend. It is something that could potentially be done. It's doable, but I just don't think it sounds right, taking out healthy breast tissue and replace it with implant, because then if you get rippling, or you see the edges, or you feel the edges, or the implants go hard, or you get a problem with the implant, you have to remove the implant, then you've lost that breast volume. So I don't like the thought of removing healthy breast tissue and replacing it with implant. But as this patient has said, it's the only way to get sustained fullness in the upper pole is with an implant. So you kind of need that discussion with them, ideally pre-op, so you don't get an unhappy patient after a breast reduction or a lift saying, hold on a minute, why do they still look droopy? Because I've certainly had patients coming to see me saying, oh, I had a breast reduction at so-and-so, and you know, they haven't done a good job. I need another breast reduction. I look at them, or another lift, and I look at them and think, no, you don't. That's actually what it should look like with a lift. But you weren't aware of that before having the surgery. You kind of had in your mind a sort of look that cannot really be achieved with a breast reduction, but that wasn't really conveyed to you, or you didn't really acknowledge that, and that's why you're unhappy, because you've actually got a good result from your breast reduction or lift, and it's really the limitation of the procedure rather than the result that's caused your unhappiness. A lot of this work is about trying to sort of get patients on side before you do the operation, so that they kind of expect what they're going to get. A lot of the problems come when they don't get what they expected they were going to get. And sometimes you look at them and think, actually, that's kind of what I expected you were going to get. And obviously not in my practice, but in other people, and if it does happen, and obviously it has happened to me, when it does happen, you kind of think, well, that's a failure of the consultation process rather than a failure of the operation, because I haven't made it clear to you that's kind of what I expected them to look like. If you're unhappy with that, I can look at results sometimes and think, oh, no, done well. If the patient didn't say anything, I'll be quite happy and go merrily along my day. But then you actually talk to the patient, heaven forbid, and they're like, well, it's rubbish, and you think, what? You think it's rubbish? I thought it was really good. And that is why I think it's important to spend time with the consultation, and I do spend a lot of time with the consultation, go over things again and again to make sure people are happy with what the plan is, to try and avoid that sort of, oh, it looks rubbish afterwards, if I think it looks okay. Managing expectations, that is one of the most difficult parts of the job. It's up there with doing the surgery, obviously doing the surgery is another challenging part of the job, full of challenges. What are your thoughts on non-surgical lifts? Who are they good for? Big shout out to whoever asked this question, because they've asked it on the story where we put that little button that says ask me a question. And actually, I think some of these questions tonight were from last week. Was it half term? Anyway, if I was here last week, someone put on this, two people actually put on the sticker that we put out, and I failed to notice it until afterwards, which I do feel terrible about. But this one, we have noticed this one prior to the Q&A, so I can incorporate it. So if you're out there, thank you for asking this question. And also, if you're out there, what you talk about non-surgical lifts, what are your thoughts on non-surgical lifts? Who are they good for? Are we talking breast lifts here? Non-surgical breast lifts. Having said thank you for this, and having said acknowledging that I did notice this question earlier, you would have thought I would be prepared for it, wouldn't you? You would have thought I'd at least Googled it. But oh no, I just come straight into this without so much as what's a do they do non-surgical breast lifts? Is there such a thing as a non-surgical? I'm going to get humiliated and shown up like I was the other week with, what was it the other week? Some kind of FUPA? Was it FUPA someone put? Everyone knew what it stood for except me. Oh, God. Fat pad removal. Anyway, don't want to bring that up again. But no. So non-surgical breast lifts. What's that? What, I don't even know what. Not. So okay. So I'll try and let's just try and get through this question. So non-surgical. Why don't we just expand this on non-surgical stuff? Yeah, because they do like non-surgical stuff like nose, don't they? Liquid rhinoplasty, they do non-surgical rhinoplasties and stuff. So non-surgical stuff. My thoughts on non-surgical stuff. Let's make it make that the question. I think it is a massively I know it's a massively growth industry. I don't think it is, and I completely understand why it's a massively growth industry. If I was having something done, if anything could be done to improve this, which clearly it couldn't be, but let's just expand our minds and just assume something could be done. If I was having something done and they said to me, do you want a non-surgical thing or do you want a surgical thing? I'd be like, non-surgical, right? I don't want surgery. The market for non-surgical stuff is everyone. Let's face it, is everyone. The market for non-surgical, whatever it is everyone in the world, pretty much, whereas the market for surgery is like that many people, hardly, very, very small portion. So I love the thought of non-surgical stuff. However, I don't do any non-surgical stuff. Why doesn't he do any non-surgical stuff? Well, the thing is, in fact, I did a blog post about this a while ago called "Less is More." No, less is not more. Less is not more, or anyway, something along those lines. Yeah. Does that make sense? Less is more. Anyway, the point is, everybody wants less. They want less scarring, less downtime, less risks. And obviously, I mean, as practitioners, we want that as well. Everyone wants less. If I could do something with less scarring and less downtime and less risks, I would definitely do that rather than the thing with more scarring and more downtime and risk. The problem is it's less of a result. So that's what I'm getting to. It's less of a result. So if there is some kind of non-surgical breast lift, let's just say there is, it's going to be less of a result. That's my thought. So who's it good for? Someone who doesn't need much of a lift is what I would say. I'm trying to think how they would kind of tighten the skin. Maybe they do something to the skin. I don't know. But I'm not aware of a non-surgical breast lift. Is it, assuming you are talking about a non-surgical breast lift? But if there is one, I'm suspecting it's going to be less of a result. But you might not. You might only need a little result, so you might be happy with it. The problem I've got, and certainly for a lot of the other non-surgical stuff, the problem I have found with it is it's quite expensive. That's the problem. If it was cheap, I think people would accept a marginal result. But I've found it's often quite expensive, like these machines and stuff you can buy. They're often quite expensive and the results are subtle. And for me, I think that's more difficult to kind of sell, if you like. I think, you're going to be more likely to have unhappy people if they've paid thousands of pounds for something and it's a subtle result. Again, it comes back to patient expectation and talking to patients and things. But I guess the problem is if you've paid thousands of pounds for this machine or whatever it is, you kind of need to get patients through in order to justify the expense to sort of make it a worthwhile thing to do. So you've got that balance there with, obviously you want to have happy patients. Obviously you don't want to do things on people who aren't good candidates, but at the same time you've got to, make it work. And that's the challenge I kind of don't want to get into. Surgery doesn't really have kind of so much of that cost, particularly because I don't run the theatres and stuff, so it kind of doesn't matter so much. I don't kind of lose money if I'm not doing surgery. I don't have that cost like you would have of a machine, and also it gives quite dramatic, demonstrable results. When I've seen people demonstrating results of non-surgical things, in terms of, I'm thinking more about the body contouring things and the sort of liposculpture, I think they call it. It's quite subtle and it's expensive. As I say, if it was subtle and cheap, I think you could justify it. But often it's like almost as expensive as surgery. And whilst I understand why people, even if it was the same price as surgery, would choose it because they don't want surgery, I completely understand that. They're potentially going to be cheesed off if the results are like non-existent. I mean, if they're, they might accept subtle ones, but if that's a non-existent, they're going to be cheesed off. In fact, they might be cheesed off with subtle ones if they haven't been counseled properly off the bat. So that's my thoughts on non-surgical stuff. And I would say that those thoughts would qualify for non-surgical lifts if we're talking facelift, breast lift. If we're doing facelifts, yeah, there are non-surgical facelifts, but I'm assuming they're doing breast lifts because I'm a breast kind of guy. But yeah, anyway, that's my sort of non-surgical stuff. I'd love. Do you know what? Would I love to just be a non-surgical person? I don't know. Maybe I would. I wouldn't mind doing a bit anyway. If I had half of my work was non-surgical and half was surgical, that would be all right. But it's all surgical at the moment, which is stressful. I'll be honest with you. All that expectation stuff, it's stressful. But, you know, don't worry. I've made my bed, so I've got to lie in it. So, but yeah, that's my view on non-surgical stuff. I tell you what, thank God I had some questions because I haven't had any live, but that's okay. It's okay. That's it for my questions. I'm out of questions. If you've got any questions, feel free to comment on this. Oh, here we go. Katie's got a question. Would you remember? Here we go. And it's a see and treat question. Love it. Katie, right. Would you remove a small milia bump right by the eyelash line? Right. First thing I'd say to Katie is we have a see and treat service. So go to bit. I can comment. Go to bit. I can comment on Instagram. .ly/C and treat to download our. Go to bit.ly see and treat to download our brochure on our see and treat clinic, which I did over the weekend. I made it. Okay. We've got like a designer who was busy, and she said it will take 3 weeks before she can do it. So I thought, you know what, I'm going to take matters in my own hands, which I've done, and I have done it. Anyway, sorry, I will answer your question. Yes. So right by the eyelash line. Well, probably if it's something like the ophthalmologist, like if it's a sty or something like that, we would probably say the ophthalmologist. Or if it's a chalazion, you know, those cysts you get by the eyelash line, we probably get the ophthalmologist to deal with it. But if it is just a small little milia near the eyelash, the fact that it's near the eyelash line is absolutely fine. We can deal with things on the eyelash line, on the eyelid. We can remove lumps, bumps, moles, skin tags, bits and bobs around that area. Absolutely fine. We would kind of just make sure it wasn't something like a chalazion or a sty. So Katie, what you can do is, I don't know if you were here earlier with the We Buy Any Car analogy. You know, We Buy Any Car says, send us your reg number now. WhatsApp us a photo now. Yeah, that's our. We're moving into the We Buy Any Car market, but instead of send us your reg number, it's like send us a photo and we'll give you an opinion. So WhatsApp us now. So on my brochure, when you download my brochure, there's going to be little links. I hope they work. The little green bits at the bottom of it says send us a photo. We've got to think of a catchy line. Haven't quite got the catchy line yet. WeBuyAnyCar.com. We remove any bump.com. Write it down. Check out we remove any bump.com. If that web domain is available. We remove any lump or lump.com. Yeah. We remove anything. No, not anything, because that could be like someone could ask for their bath to be removed or something. Anyway, Katie, WhatsApp a submit photo. We'll have a look at you and get back to you within 30 seconds. Not quite 30 seconds. 30 hours. That doesn't sound so good, does it? 30 hours. Yeah. Simply WhatsApp your photo and we'll get back to you within 30 hours. Sounds rubbish, that, doesn't it? Or 48 hours if it's a weekend. Yeah, that's rubbish. Anyway, we won't guarantee when we'll get back to you. We remove any lump.com. We remove any. Anyway, So yeah, just the fact that it's by the eyelash is fine, Katie. We can deal with things near the eyes. We are plastic surgeons after all, and we're fine with that. Thank you for asking a question, by the way. If anyone else has got a question, they can do what Katie's done and just put it on there. If it's about something see and treat, even better, because I can promote the fact that I've done oh, here we go. Type something in here. I'll type it in Facebook like bit.ly/C and treat. So please check out my brochure. What does that mean? Host chat? I don't know what that means. Public. Anyway, please check out my brochure. Let me know what you think. If I can improve it, just let me know, because I made it, so I can improve it. I can just go back to Canva and just adapt it. So if you've got any feedback, let me know and I can change it. Not like the other one where we have to get the, it's all on a PDF, so the designer have to change it all. So be very responsive to any feedback on that. But anyway, I'm digressing. I'm not digressing. I'm just going on. So thank you all for being here. Very grateful for your attention. If you do have any questions that you want me to answer, then just message me on Instagram or Facebook or YouTube. Let's not forget we're on YouTube. We're live on YouTube. So just comment in the comment bit, or private message me on one of the aforementioned vehicles, and I will be very happy to get back to you. But for now, I'm going to let you get on with your evening. I'm going to say bid you a very good night, and until next week, have a wonderful week. I hope the weather isn't so labile as it is at the moment. I hope it brightens up a bit. And yeah, hope we have a Barbie this weekend or something. So yeah, I guess I'll sign